Okay, this is my first Instagram live. So I'm just going to give a couple minutes for people to join in. Okay, we got someone. So yeah, hopefully the tech is working okay for this. I did a little test run. So I'm just going to wait a few minutes for some more people to join. Let's see, we got some more people joining. And oh, hello. So as people are kind of filtering in, I'm just going to give a little intro of what I'm doing here, why I'm doing this series. I'm going to be doing, like, maybe probably going to be 4 weeks or so where I'm going to be doing these Instagram lives on a weekly basis to just go over the fundamentals of PTSD and trauma. And the reason is that I find that there's no condition that is more treatable but so misunderstood that leads people to not getting the treatment that they need. And so, and honestly, even among professionals, PTSD and trauma is really misunderstood. And I've talked to so many people who believe that PTSD is a chronic condition that you're just going to have for your life. And there's nothing further from the truth. It's so addressable, and it's actually one of my favorite things to treat, because someone can go from struggling so much to being better in a couple of months. It's one of those conditions where there can be just a really night or day difference in how people feel. So that's kind of why I'm doing this. And let's see here. The way this is going to be structured is today I'm going to be talking about what PTSD is, how it's triggered, and what it looks like. You know, how do you know if you have PTSD? How do you know if someone you care about has PTSD? And talking a little bit about what the daily experience is like. What does it feel like for someone who has PTSD or post-traumatic stress disorder? And then at the end, I'll be answering some questions. So I got some questions in advance, and people may have, if questions come up as I'm talking, just put them in a chat. I'll try to get them at the end. So, okay. And honestly, after even just this little Instagram live, you're going to know a lot more about PTSD than the average layperson, but you're going to know more than some professionals, because it's such a specialized area. And so I'm really happy to be doing this. Okay, so just a little bit about my background. I both specialize in treating PTSD and had PTSD after getting cancer, and then got treatment for it. And now I really specialize in it. So when I was in residency for psychiatry, I already just had an interest in PTSD. I took a year-long clinical internship specifically treating Iraq, Afghanistan, Vietnam vets with trauma and post-traumatic stress. And then I was in my last year of residency when I got cancer, and got treatment over the next few years. And then it took me actually a little bit to recognize, even though I already knew what it was, that I had it, because I was so physically sick for a while. And it wasn't until maybe a year and a half after chemo that I wasn't so physically sick that I noticed, all right, I'm not physically ill, but I'm not feeling great. What's wrong? And because I had specialized in it, I knew what kind of treatment I needed, which is exposure therapy. I'll talk more about this at the end, but I got a specific treatment called prolonged exposure. I did around a 5-6 month course of it, like night and day better. And then I was really good at treating PTSD. So people would seek me out for it. And then I relapsed maybe 3 or 4 months after I finished the treatment. And if I had not gotten treatment for PTSD, my relapse would have been a very different emotional experience. It really wasn't that traumatic, to be honest with you. For a couple weeks, I was like, oh, I'm going to die. This is a bummer. After that, when it seemed like I wasn't going to die, I got over it really fast. And the key is that in order to overcome your fears, you have to face them. to overcome your fears, you have to face them. And with PTSD, you got to like run into the wind. Okay. So what is PTSD? Two things. It involves one, the exposure to a traumatic event. So this can be something really obvious like an attack or a rape or a natural disaster or 9/11. It can be something that was more chronic like childhood abuse. It can be something like cancer where I did have one event during my treatment that was really traumatic, but even without that I probably would have had PTSD where it's kind of multiple events over time that just cumulatively cause it. COVID is a situation where if you're seeing people you love die or get really sick or hearing stories about it, that can count as a traumatic event. What doesn't count, and I don't mean that it's not really significant or distressing, but from a diagnostic standpoint, is more just everyday stress where there isn't a threat of death. There has to be some sort of threat of death either for you or someone else that you care about. So, but this is the interesting thing. Exposure to having a traumatic event doesn't necessarily lead to PTSD. And in fact, usually it doesn't. In about like 70% of cases, it doesn't. So what's the difference? And this has been studied after major catastrophic events like 9/11. So you go and you interview people immediately in the aftermath of 9/11. They did this. And something like 70-80% will have symptoms of PTSD, and I'll talk in a second about what those are. But then you go back 6 months later, and it's only around 30% who do. So what happened there? And the key difference is avoidance. So the people who develop PTSD are the ones who try to avoid reminders and triggers. It's kind of counterintuitive, like, well, I don't want to wallow in it. But that's exactly what leads to the problem. Because if you have something really traumatic that happens to you, your brain is naturally it's learning. Now, it's learning the wrong things. It's learning that, oh, wait, the world is a really dangerous place. Like, I'm not safe, ever. People can't be trusted. The world can't be trusted. Like, I'm in danger at all times. And if you then avoid everything that challenges that, then that belief gets reinforced. This is called fear conditioning and fear consolidation. And that's why PTSD is not even diagnosed in the first month after a trauma. It's called acute stress disorder. And in fact, I don't really diagnose PTSD until maybe 6 months after the trauma. Now, I'll still do treatment earlier. It's better to intervene earlier. But it's more of a failure of recovery. I don't mean moral failure, but just a lack of recovery after a trauma than it is just being exposed to a trauma. So there's symptoms. There's 4 clusters of symptoms. So one, traumatic event, and then at least a month later, if not 6 months later, you develop cluster 1 is re-experiencing. So you re-experience the event in traumatic, difficult ways when you're exposed to a trigger. So that can be nightmares, it can be flashbacks, it can be intrusive memories, like it's just popping in your head randomly. It can be like a TV show comes on that's somehow related to the topic and you just like, oh God, I gotta turn that off. That happened to me. Like anything related to cancer, like a commercial for, St. John's or whatever, like, okay, I gotta turn off the TV. Just little things like that when I was dealing with this after my cancer treatment. And to be very specific about what a flashback is, this is misunderstood. A flashback is not like it popping in your head. A flashback is you feel like you're back there in that moment. You've dissociated, you're out of your body, and it's like you're in that moment where it's happening again. It's a very extreme reaction, so that's actually less common. The intrusive memory is very common, like it's just popping in your head and causing a lot of extreme stress, like a very strong emotional response. So number 2, symptom cluster, avoidance. There is no PTSD without avoidance. Now there's types of avoidance that are really obvious. So like after 9/11, for example, you don't go near the site I mean, or someone who went through it too, you avoid talking to them, you avoid talking about it. But so it's like avoiding people, places, or situations that remind you. It's also though avoiding thinking about it. So if every time it pops into your head, you're like, okay, push that out of my head. That's like an internal avoidance, and that counts too. That also reinforces the belief, this is happening kind of subconsciously, but the belief that the thought is dangerous. And if you feel that thinking about it is dangerous, then like everything has to get suppressed. Like, and so a person will feel like, well, I just don't feel anything. So that's why people describe this feeling of numbness. So cluster number 3 is negative perceptions and beliefs. So like I was saying, when you have one dangerous thing happen, like what happens that's pathological is, oh, it gets generalized. Okay, this one person attacked me. Nobody can be trusted. You know, like I just can't open up to anyone. The world is not safe in general. So instead of just the fear or the negative thoughts being specific to the event, it's like, no, the whole world isn't safe. I can't be safe. It can be like, it's my fault. It's like, oh, I'm at fault for being, raped or whatever. That's also a distorted belief. And then problems with attention or concentration. People have memory problems. They might have trouble remembering aspects of the traumatic events. That's very common, where they don't remember, especially the worst parts of it. And then symptom cluster number 4, physiological arousal. So like constantly on edge. My patients who were veterans, I mean, so what they would describe, it's called hypervigilance, scanning their environment at all times. Like going to the grocery store, I could take that guy down, I could take that guy down, I couldn't take that guy down, so I'm going to leave the grocery store. I mean, just like this, like something happens in the corner of your eye, like, and then there's something called startle response, where like someone taps you on the shoulder and you just jump out of your chair. Or a voice that's in a normal volume and you're just like jumping out of your chair. So that's called an increased startle response. And then just very, very intense physical arousal, like panic attacks or anxiety when reminded of the trauma, or just kind of all the time. So now that's kind of the clinical diagnosis, the symptoms, but let me tell you what it's like in terms of the daily experience, like what my patients describe. So first of all, the person's life becomes centered around avoidance. So I had a patient who had PTSD, and he didn't identify it was a problem. He said he was a veteran, and he said, oh, like I used to have a lot of anxiety, but like I don't anymore. I'm like, oh, that's great. What did you do to solve the problem? Like, oh yeah, well, I just like stay home. And I like quit my job, and I broke up with my girlfriend. I stopped talking to my army buddies, and, like everything's great now. And when someone brings it up, I change the topic really fast. I'm like, well, that's great that you feel that's better, but your whole life you're not better. You feel better because you're just avoiding the whole world, anything that could trigger you. So like what people's daily experience is that like they structure their day all around like, how do I avoid triggers? Another thing my veteran patients would do was people just in general avoid public spaces, crowded spaces where they feel like they couldn't escape easily. So I have patients that would go to the grocery store, but only at like midnight. They'd find the 24-hour grocery store and go when no one was there. Or if they, God forbid, have to go to Starbucks or something, they are sitting with their back like against the wall, like to the door. They never sit with their back to the door. They sit with their back to the wall. They never sit with their back to the door because they can't see everything going on. Another patient who was sexually assaulted in her home, she had like 6 deadbolts, so she'd check them 12 times. She got all these crazy locks on her windows installed. So just, it's like this avoidance of talking about it, avoidance of seeing friends. Like you just stop talking to certain friends that, maybe knew about it and you don't want to bring it up. The other thing that people describe is, and this is where it's different from depression, is people don't necessarily feel depressed. And this is what I experienced. You just never feel happy. It's just like, I never feel awful, but I don't experience any positive emotions anymore. I don't feel joy. I don't feel excitement. I don't enjoy things I used to enjoy. And the reason for that is because when you're avoiding your internal emotions, your brain, like you're trying to suppress the negative emotions, right? But your brain doesn't really know how to do that selectively. It just suppresses everything. So you are also suppressing positive emotions. So that's why people feel emotionally numb. People also get very detached, like socially. So they just don't feel close to people. I experienced this too. I mean, I had so many friends like who were reaching out to me and I just wouldn't text people back, or, you know, just wouldn't feel like talking to people. And it wasn't conscious like, well, they're going to bring up cancer. It was just, I don't feel like talking to anyone, you know. And so that's the other thing my patients describe, is that their just social circle has shrunk, not because they don't have the option of friends, but because they just feel like they're kind of underwater and like everyone else is somewhere else. It just feels like on my phone. Okay, so now before I answer some questions, I'm going to talk more specifically about the treatment in my next live, Instagram live, but I at least want to explain that this is super treatable. Like I said, when you're the solution to your fears, like the only way to overcome your fears is to face them. So the exact opposite of what people want to do when they have PTSD, which is expose themselves to triggers, is exactly what the treatment is. So I did a type of therapy. This is what I learned how to do in residency that I then got done on myself because I knew about it. Now I also do it on my patients. It's called prolonged exposure. And there's a couple other types are cognitive processing therapy, or CPT, EMDR, which I always forget exactly what it stands for, eye movement and desensitization, reprocessing, I think. Those are the three big ones, and maybe someone could comment if they know of. I really think those are the only three. There might be new ones getting developed, but they're all some version of exposure. To be honest, everything else is you're beating around the bush. You can talk around your trauma for like 40 years and not get better. You can do body somatic therapies for years and not get better. And this is not is a criticism to those therapies at all. But if you're doing anything, and they can be good ancillary treatments, but if you're doing anything other than going over each specific memory in excruciating detail while recording it and then listening to the recordings later, you're not doing real treatment. So anyway, I want to answer some questions. And so if anyone has any questions, I'm just going to scan up and see if people ask questions. So if you have questions about that, like throw them into the chat. But I got a couple of questions in advance that I'm going to answer now. One, and this is from a COVID ICU nurse in San Diego. How does it look like? How can I identify it? And I talked a little bit about that, but I'm sure she's talking about with her patients. So I'm going to answer this specific to what do you do when you're like kind of like a first responder. And this you've really caught people before they have developed PTSD. So because again, it's not just being the trauma itself, it's not recovering because you're avoiding. So what's most important to do if someone is currently going through a trauma, because you can't really treat it until the trauma is over, is be supportive and not change a topic when they bring it up, and then kind of encourage them to talk about it to whatever degree they want, showing that you're a safe person that they can talk to, because when that person would develop PTSD would be like in the weeks and months following if they become isolated and they start avoiding. So like what you might see acutely is just like someone having panic attacks, someone having nightmares, like even if it's not nightmares, like shooting up in the middle of the night, like like that kind of, not just you have to pee and you're awake, like just shooting up with anxiety, startling easily, the startle response. And but again, even if someone has those things immediately in the aftermath of a trauma, they don't necessarily have PTSD, because it really has to happen for at least a month after. All right, and another question I got is what to do when you have flashbacks to a traumatic situation. And I'm going to answer this on two levels. I mean, the short answer is you have to get exposure therapy. That's the long-term solution. But in the short term, what do you do in that moment if you're dissociating? And so this is when you feel like you're outside your body and you're reliving the trauma, doing some sort of grounding technique. And this is something that you can do for yourself if you've had a traumatic event, or if you're with someone who's experienced a trauma and this is happening to them, they're kind of losing it in the moment, is help them get in touch with a physical sensation in the present moment. So like hands in ice water, something that's like, wow, this is a very distinct physical sensation. So like I can focus on that. Focusing on the sensation of your feet on the floor, focusing on the sensation of your seat on the chair you're sitting on, something that exists in the present world, which is a sensory experience, and touch is a really good one because it's like, I'm touching this. So it's kind of like a mindfulness meditation. And if just the touch is, sometimes if a person's really dissociating, they're having trouble connecting with like that present moment, then something like ice water is really helpful because it kind of is like a stronger sensation. So you just want to help reorient that person or reorient yourself to the present moment to kind of de-escalate it. So is there a specific type of therapist? This is another question I just got. Is there a specific type of therapist who offers exposure therapy, or would all therapists offer it? Now this is where it's like the unfortunate, like, do not just expect that any therapist will know how to do this. Most don't. And this is why, unfortunately, a lot of people are like spinning their wheels, even if they're getting treatment, that the therapist may not know about this. So on what's the website? Let me pull this up. On exposure. Edna Foa. The person who developed this, her name is Dr. Edna Foa, F-O-A. And there's a really good book. It's under the treatments that work. It's like a series called Prolonged Exposure Therapy for PTSD, or How to Overcome Your... There's like a workbook and a therapist guide. The workbook is a good one that goes over how to do this. That's something you can take to a therapist and say, like, do you know how to do this? Also, when you're like screening, say, do you know prolonged exposure, EMDR, or CPT? You really want to be screening. And then the website I'm looking for is, it's UPenn. So med.upenn.edu, and I'll like Instagram this out. Essentially, the Edna Foa, the person who founded this type of therapy, developed it at UPenn, and they have therapist listings on their website where it's people who have traveled there to UPenn and done this certification. Now that it's kind of slim pickings, because only so many people are listed on their website, and this is only if you're in a major city. And for example, people like me who haven't done that training, but done training somewhere else won't pop up. But yeah, when you want to find someone who very specifically knows how to do this, but also educate yourself, get that book, that Edna Foa Treatments That Work book, because you can do this a lot on your own. Like I just saw a patient who just like this horrific childhood trauma, but amazingly had kind of figured it out on his own. Oh, when I talk about this, like I stopped associating, and so now I'm just talking to my friends and now I'm better. A lot of people can get better without formal treatment if you are intentionally seeking out exposures. Like, so it's kind of like a mental shift from, oh, I'm feeling triggered, I gotta like shut this down, which is sometimes when I see trigger warning, I'm like, no, trigger warning, you need to read that. Like, no trigger warning. I probably should have said trigger warning before this because I'm like talking about all these crazy things. So All right, I don't think I have any more questions, but I'm just going to end with a really brief story that you guys will find interesting. And this patient has given me permission to just describe her story without identifying details. She's gotten so much better, and she says, "Oh, I want you to just share with everyone about what my experience was like, and so it can help others or whatever." So this woman was raped by the Golden State Killer in the 80s when she was in law school. And I don't know if you've ever watched like that Golden State Killer documentary, but it's basically like that's what happened to her. She wasn't fortunately like physically injured, other than, I mean, being raped. She wasn't, he didn't like stab her or something like that. But what he would do is he'd stalk his victims in advance and unlock their windows, and then go inside. And then when you'd walk inside, like, you'd think you were alone, and then he'd pitch black, like, light a match in the corner of the room, and like you just see this guy's face in a ski mask. And that's what happened to her. So like I said, this was decades ago, and this affected her whole life. I mean, her marriage, her relationships with her kids. She had no idea that there was something like this kind of treatment that existed. And I think it was in the context of like her marriage kind of going downhill. And I just remember when I first told her, like, look, yeah, I can treat this. This is what you're going to have to do. You're going to have to like talk about this, and we're going to have to go into detail, and you're going to describe it in the present moment as if it's happening now with your eyes closed, and you're going to try to relive it as you're saying it, and then you're going to record that on your iPhone, and then you're going to listen to that recording every day. And she's like, are you kidding me? She's like, Dr. Miller, are you kidding me? We laugh about this now. And I'm like, yeah, no, I'm not kidding you. You're going to do this. And that's actually why a lot of therapists don't do this treatment effectively, because it's kind of hard as someone who, if you're a therapist, you care about making your patients feel better. This is kind of like you got to make them feel worse before you feel better. So it does take some experience. And I both given the therapy to patients and then had it done myself. So anyway, she's like, okay. And like that first time we went through it, she was like crying, dissociating, like just like I had to do some grounding techniques. But you know what? She went home with that tape. She came back a week later. She's like, yeah, it's not so hard now. I find that once you listen to the tape about 5 times, it's not so hard. And now she also had this horrific childhood abuse. We had to go through and do exposure therapies, exposure sessions for that too. So it's been a couple years. Her life is like night and day different. I just saw her the other day, and she honestly keeps saying, please use me as a case study. She had PTSD for 40 years and thought this was something that she'd have to live with for the rest of her life. And 2 years later, she does not have it anymore at all. And her relationships are great. Her family's great. I mean, so that's why it makes me really sad when I hear people think that this is a chronic problem, and it's not. It's not. So anyway, I talked for longer than I meant to. I've been talking for like 30 minutes. So I'm going to be saving this and uploading it to my I don't know, the person who helps in my social media is going to help me upload it. Thank you, Kate. And next week, I'm going to be going into more detail. So same time, about what is exposure therapy, what the process is in like excruciating detail, and why it works from a emotional, biological perspective. Okay, thanks you guys, and I will see you next week.